this. The UP consists of 8 modules. Now, all those modules focus on emotion and emotion regulation. There's 8 primary modules. The first module is really about trying to get people motivated to engage in the treatment. The second module is provide psychoeducation on the nature of emotions, why we have emotions, why they're important. And it also gives people a way of tracking their emotional experiences. So we cover the 3-component model of emotions. And then we also describe something we call the arc, which is the arc of emotions, which is essentially triggers of an emotional experience, the emotional experience itself, and then the consequences of engaging in, typically for people, emotional behaviors. And then from there, we go to module 3, which is focused on mindful emotion awareness. So mindful emotional awareness is an interesting module. It's not simply mindfulness. You know, people think of it sometimes as trying to jam mindfulness into this protocol. It's not really what it is for us. You know, for us, it was about helping people to become more connected with their emotional experiences in a present-focused and non-judgmental way. And so we find mindfulness to be useful in helping people to achieve that, but it's used as a means to an end. And the end that we want is we want people to become more connected with their emotional experiences in a way where they're not immediately trying to suppress the emotions or avoid the emotional experience. And that's how we use it in module 3. Module 4 is what we call cognitive flexibility. The purpose of module 4, really 4, 5, and 6 are really trying to focus on the 3 primary components of the emotional experience. And so module 4 focuses on cognitions and helping people to think in a more flexible manner. Module 5 focuses on behaviors, and that's really what we would describe as emotional behaviors. Now, emotional behaviors can take many different forms, but we sort of have 2 broad categories: avoidance and then emotion-driven behaviors. And so we're essentially trying to help people to change their behaviors as a means of adaptively or changing their emotions. And it's not so much changing; it's just sort of being able to respond to the emotions that somebody experiences in a healthy way. So to say, okay, well, I'm feeling this way, so instead of responding in this typical way that tends to have negative consequences for me, I'm going to respond in a way that is going to lead to more positive consequences and be more in line with what I want. Module 6 is about the physical component to help people become more comfortable with the physical component of their emotions. And then finally, module 7 is where we bring everything together and we practice utilizing the skills, ask people to practice utilizing the skills in the context of a strong emotional experience. And so to do that, we ask people to confront situations that are likely to provoke strong emotions. Then finally, module 8 is a wrap-up module. It's really about where the person has come from the beginning of treatment and then where are they going. So those are the primary components. It's 8 modules. We do them sequentially. You know, some people have begun to experiment with the idea of doing certain modules before other modules, but I think generally speaking, it's best to do them sequentially. As it's laid out now, the modules are not self-contained. So what that means is that they're not meant to just be for somebody to just pick and choose which modules. It's still a comprehensive program. You might be able to use some of the modules in that way. You might be able to pull out, say, a cognitive flexibility module and insert it into another treatment that you're doing. But generally speaking, for the UP, for the whole protocol, we wanted those modules to be sequential. There is some flexibility, however, in terms of the structure and for clinicians. They can spend more or less time on each of the modules. You know, we have some recommended module lengths that are in the therapist guide, but sometimes therapists will spend longer with a particular module depending on what they feel the client needs. So we're not trying to eliminate, you know, a lot of people have this negative reaction to manualized treatments. And that's one of the advantages of the UP, in my opinion, is that it has flexibility with it built in. I think for clinicians, I like to think of it as bringing out the best in clinicians as opposed to restricting them or tying their hands in some way. I think it's a manualized sort of protocol, but it has enough flexibility that it really gives the clinician a tool to practice their craft, to really practice what they're good at, as opposed to really dictating exactly how they present the concepts and exactly how they have to do the treatment. That there's still some flexibility built in. And, I fought really hard for that over the years to make sure that we got that in there, and to make it different than some of the manualized treatments that I think have come before it. And so, clinicians can spend more time in a module. Like oftentimes people will spend a little more time with the mindful emotion awareness, or they might spend more time with cognitive flexibility. And I think people like that, having some flexibility in terms of the treatment. In terms of the length of treatment, I think the recommended length in the therapist guide is 12 to 16 sessions. But I've taken it further than that, depending on the amount of time that I might spend in any given module. And with some patients, I'll go back and revisit modules at the end, that I feel they may need to work a little bit more on. But by the time you make it to module 7, when you're doing emotion exposures, that's really the point at which you're practicing those various skills, or working with your patient to practice those skills. So you might spend a good amount of time in module 7, and that essentially is, think of it as like continued application of the skills, basically. So 7, and then it leads into almost a consolidation period where you're helping somebody to practice on a regular basis those skills. We've done it in shorter lengths, like 8 sessions. I think we actually had a 5-session protocol at one point where we focused just on some of the core modules. The core modules for us have been modules 3 through 7, although there's a lot of debate within our group of whether module 2 should also be a core module because of the psychoeducation component. But generally speaking, I think modules 3 through 7 are considered core. And so we've conducted treatments in which we've really focused on those core components as opposed to some of the other modules, and that tends to shorten the treatment. But it's like anything, I think the more time you spend, generally speaking, if you take your time and go through the protocol, you're probably going to see better results. But it depends a lot on the context in which the treatment is being used. Usually those are more primary care hospital settings where they'll ask us to create a shorter protocol where they're limited in the number of sessions that they can provide. So in terms of structure, we usually do it individually, although there's been a number of papers published on groups using the UP. Interestingly, and I think Dave will probably say, he'll probably tell you the same story, but the UP was originally developed as a group treatment. That when it first, the pilot work in it was a group treatment, and that was one of the big advantages that we saw of the Unified Protocol. But when we presented it to the National Institute of Health to get funding for a large trial, they wanted us to go individual with it to sort of take out some of those factors that might influence the efficacy of the treatment. So we switched over to an individual format and have pretty much used it in that way ever since. And then, a lot of our colleagues and other researchers around the world have started to use it as a group treatment, because I think there are some advantages to the UP in a group setting. I mean, you don't have to have a group specifically for a disorder. Rather, you're just, applying the skills to a number of individuals in the same setting. And there's some really nice things about it, I think, as a group treatment. I do like, however, the fact that the UP focuses on underlying mechanisms or underlying sort of psychopathological processes that are really related to a variety of different disorders, as opposed to getting caught up in all the symptoms of the different disorders, right? And here, the big focus, I think, is on emotion, how people experience their emotions and how they respond to their emotions. Dave will talk more about neuroticism and the role of neuroticism, hopefully in your interview. And I would try to get him to talk about that because it's really fascinating, his thinking on that. And but when I think about it as a clinician, and I've worked with it extensively as a clinician, for me, I like that I don't have to, I sort of get beyond the diagnoses. You know, I put those mostly to the side. I mean, I might want to know the symptoms that the person is experiencing, but I always bring it back to the model. And that allows me to address comorbidity in a way that I couldn't do that before, right? I mean, I'm able to talk to the person about panic attacks that they have without really worrying, do they have panic disorder, or not getting caught up in whether they have panic disorder or not. It's like they have panic attacks, they worry about the panic attacks. They also worry about other things in their life, right? So I'm able to address all those things at the same time using that protocol. The other thing that I found as a clinician is that people can relate to it in ways that they often struggle with relating to other protocols. They can relate to the idea of emotion. They see patterns of avoidance. And frankly, they recognize that those patterns of avoidance that they're engaging in, regardless of whether it's in something related to social anxiety, or whether it's something related to worry, or whether it's something related to panic attacks, they recognize that they need to address that avoidance. And that's actually, I think, the terms that people use when they think about their own difficulties are much more consistent with the UP than they are probably with some of the other protocols I've worked with. So I see that as an advantage of the UP. The other advantage that I see with the UP is that I find that talking about difficulties around emotion is much less stigmatizing than talking about diagnoses. So if somebody comes into treatment and I do an assessment with them, and they, you know, at the end of the assessment, I give them feedback, right? And I say, well, you know, you meet criteria for, you know, 1 disorder, 2 disorders, 3 disorders, 4 disorders. I go down the list. And they feel pretty lousy walking out of that room. I mean, they feel like they're you know, crazy, or that they have these significant, that they're just the psychopathology, you know, even that term psychopathology, but they're just sort of like psychopathological, you know, they think of that. And we're actually, with the UP, we're trying to move them away from thinking about themselves in that way, right? Think about module 3 of like, we're trying to reduce the judgment that they have about their own experience, about their own emotions. The reason for that is because the judgment actually intensifies the emotional experience. So if somebody's thinking to themselves like, okay, I'm depressed, and then they're upset with themselves for being depressed, they feel bad about themselves because they hate themselves because they're depressed, it's only going to contribute to more depression. Similarly with worry, you know, there's that idea of meta worry. I'm worrying about something, I'm worrying about my worry, jacking up the anxiety, okay? So we take this approach where we talk about it within like this model that helps people see it as like, it makes sense, right? I mean, this is why they're experiencing the emotions they're experiencing, not because there's something wrong with them, but because they've learned to respond in a certain way, you know, and they've learned to respond to their emotions in a certain way that have intensified and sort of created emotions that are too strong given the situation. And I think that's a much easier pill for people to swallow. It's much less egotistonic, you know, it's not damaging to their sense of themselves. They're able to look at it in a way where they say like, okay, well, that I understand that, right? Because people will say like, I don't know why I'm afraid of this thing. But then when you actually break it down and you walk the person through it, and they go, okay, yeah, now I understand. It got established over time. I couldn't have done anything differently. I did what I did. Now I need to change it. And that's a very different way of thinking about problems that people are having. I think it's much more in line with like Jackie Person's approach. It's much more in line with even a more process-based type of approach that I know Steve Hayes has talked about and other people are talking about now. It's just much kinder in many ways, and understanding the problems that people are having. So I see that as another advantage clinically, using that. And then there's all the other advantages and strengths of a manualized approach. I mean, I think of myself as a pretty good clinician, but if I get off track with some patients, like it's can be a disaster. I mean, I still struggle. It could still be a struggle, you know, and I find myself then wanting to bring in components later on after say 6 or 8 weeks where I'm like, okay, now we're going to do this protocol. And then I feel terrible to do that because I should have done it from the beginning. And the reality is like it helps keep us structured. It helps keep us on track. It helps give them some structure and some guidance, right? Some of these concepts could be hard to understand, I think, for people. And the UP, I mean, what I like about it is that it's not so strict, but still provides some guidance. So it's sort of a flexible, fixed approach, I suppose, to doing treatment and to doing CBT. So those are some of the advantages. And then, of course, there's advantages in terms of training and helping other people to learn the protocol that, you know, you can't train people anymore in 6 or 7 protocols. It takes too long. And I'm not sure there's any advantage. Anybody that has learned a whole bunch of protocols always come to the same point. All the good clinicians always come to the same point where they say, well, these look very similar. It doesn't matter whether it's GAD or social anxiety. They all look pretty similar to me. It's to the point where people just start talking about, no, they have an anxiety disorder. They don't even specify which one anymore, you know, or the doctors will say, well, they got anxiety and depression. Okay.